What is the difference between diverticulosis and diverticulitis? Hi, it's Dr. Fan here. Let's talk about diverticular disease. Let's start with diverticulosis. This is a disease of the colon where sac-like protrusions, known as diverticular, pop out along the bowel wall. This is a very common condition that increases with age, affecting 20% of the population by age 40 and 50% of the population by age 60. Risk factors include dietary intake high in meats and fats and low in fiber, as well as smoking, obesity, and physical inactivity. A diverticulum develops from a weak point where the vasorector blood vessels pass through the muscularis layer. Muscle contraction and increased intraluminal pressure cause herniations of the mucosa and submucosa through the muscularis, but these are still contained by the serosa. Because they are caused by pressure and do not include all layers of the bowel, they are known as pulsion or false diverticular. The sigmoid colon has the smallest lumen diameter and the highest intraluminal pressure, and is hence the most common location for diverticulosis. However, in Asian populations, diverticulosis is more common in the right side of the colon. Diverticulosis typically does not cause any symptoms until there is a complication. So what is diverticulitis? Diverticulitis is a complication of diverticulosis involving inflammation of the diverticula. It occurs in 5 to 10% of people affected with diverticulosis and is most common around the age of 60. Inflammation is thought to occur from increased pressure in the bowel lumen, leading to food particles irritating the wall of the diverticulum. Diverticulitis presents with the symptoms of pain, nausea, and vomiting, as well as signs of localized or generalized tenderness and peritonism. Most cases will resolve with non-operative management, but of these cases, 20 to 50% will recur in the future. Around 15% of people with diverticulitis will develop a complication. Acute complications include abscess formation, perforation, and peritonitis. This is due to severe inflammation leading to necrosis of the diverticulum wall and subsequent leakage of colonic contents into the peritoneal space. Diverticular abscesses can be classified according to the Hinchey classification. 1. Pericolic abscess. 2. Pelvic abscess. 3. Purulent peritonitis. 4. Feculent peritonitis. Delayed complications such as obstruction due to bowel wall narrowing from chronic inflammation and fistula formation due to inflammation affecting adjacent organs such as the bladder, vagina, uterus, and small bowel. Investigations include blood tests, which will reveal an elevated white cell count and C-reactive protein, and CT scans, which can demonstrate a range of changes from colonic wall thickening and fat stranding to pericolic abscesses and free gas. Treatment depends on severity. For uncomplicated diverticulitis, antibiotics, bowel rest, and analgesia are usually sufficient. For small contained abscesses, it is possible to perform a percutaneous drainage under interventional radiology. Perforated diverticulitis with free gas and gross contamination require an operative resection. Patients are generally very sick, with up to 20% mortality rate seen with feculent peritonitis. Therefore, the safest option is a Hartmann's resection of the affected bowel with the creation of an end colostomy. Once resolved, it is possible to reverse the stoma to restore continuity of the colon, usually in 6 to 12 months. In high-volume centers, it is possible to perform a colon resection with a primary anastomosis and defunctioning loop ileostomy. A stoma is still formed, but loop ileostomies are easier to reverse and therefore more likely to be reversed than an end colostomy. Diverticular-related large bowel obstructions also require resection, both to relieve the symptoms of obstruction and to assess for any underlying cancer. Diverticular fistulas are also treated with a resection of the affected bowel. Fistulas to the affected organ, bladder, vagina, uterus, or small bowel generally heal well with complete closure once the offending colon is resected. Following acute treatment, a colonoscopy is recommended 6 weeks after resolution of symptoms to assess for any underlying malignancy. Unless, of course, a colonoscopy has already been performed recently, usually within a year. A high-fiber diet is also recommended to reduce future straining and formation of new diverticula. There is no evidence on specific foods such as seeds and nuts causing diverticulitis. There is another common complication of diverticulosis, being the diverticular bleed. This is the most common cause of lower gastrointestinal bleeding in adults, affecting 5 to 10% of those with diverticulosis. Of these bleeds, 30% are large volume, requiring intervention. The underlying cause is due to the diverticulum herniating through an area of weakness near the vasa recta. These vessels therefore end up closer to the mucosa and are more predisposed to injury and bleeding. The bleed spontaneously stops in around 75% of cases, but the risk of bleeding increases with recurrent episodes. And after 2 bleeds, the lifetime risks increase to about 20 to 50%. Investigations include blood tests and a CT mesenteric angiogram. These may show a low hemoglobin and active bleeding. The first-line treatment of active bleeding in Australia is generally angioembolization with interventional radiology. Endoscopic interventions with a colonoscopy can be performed, but the usual techniques of adrenaline injection, bipolar coagulation, and hemostatic clip application are less effective when the bleed comes from inside a diverticulum. If the bleeding continues and location is previously identified, then a segmental resection of the offending colon can be performed. If the source of the bleeding was not identified and the patient is hemorrhaging, a subtotal colectomy with an end ileostomy may need to be performed to save the patient. Prior to committing to a subtotal colectomy, it is important to check the anal canal for an alternative source of bleeding, such as a bleeding hemorrhoid, which will not be treated with a subtotal colectomy. While I hope that you have learned something new, please listen again and reinforce your learnings, because repetition is the key part of learning new information. And please remember to like, subscribe, share, and comment for more videos.